There was a study done. It was an insane study. So it's about 10 to 15% of the female population has PCOS, whether they know it or not. They studied this one group. It was like a women's conference. There was like, I think, 1,000 women at the conference. They took them aside. They did a representative analysis. They did a study, and they said that sure enough, 10 to 15% of these patients had it. Okay, diagnostic criteria of ultrasound, irregular periods, and the hyperandrogenism, right? And the blood work. 70% of them didn't know that they had it. Okay, so they found these patients that had this disorder, disease, but 70% of them didn't even know they had it. Whether they had to multiple doctors that kind of just keep giving them birth control pills, but they never really talked to them about it.
If you love what you're hearing in this podcast and you really want to start working on your hormones naturally, you can get a 10% discount. Go to metabolicblueprint.com/pod, POD10, and you'll receive 10% off your order. And again, that's metabolicblueprint.com/POD10. Get your hormones balanced today.
All right, Dr. Weiss, I am so excited to talk about this topic because I think it's definitely something that gets overlooked in traditional gynecology and definitely in the broader sense of the medical community, particularly the polycystic ovarian syndrome. But before we get into that, I'd love to know, how did you get into OB-gynecology? You're a guy.
Yeah, it's a great question. Often asked that. From a very young age, I'm 53, so I always wanted to be a doctor, and I always wanted to do something surgical. And I always felt I had good hands, and I wanted to be doing something surgical and some surgical subspecialty. And I went to medical school at the Ohio State University, and had an unbelievable, like off the charts, top of the line experience there. Dr. Steve Gabby, Mark Landon, Phil Samuels, they wrote the book. When I say they wrote the book, they did. Gabby's OBGYN, and they were so incredible in education. And Larry Copeland was the head of GYN oncology, and he wrote the book on GYN oncology and surgery. And I saw a surgical subspecialty such as OBGYN, but not just treating hernias or not just, bowel surgery or colon or whatever the case may be. You're not like when a patient comes and says, oh, this is the appendicitis or this is the hernia, and then you do the surgery, and then, maybe they come back and see you, maybe they don't. And I felt that was missing some of that patient contact that I was going into medicine for. And I saw in OBGYN a field where I could take care of patients in their younger years, and then, I want to say age with them, but then kind of grow with them and deliver babies and do surgeries if they needed it, or C-sections if they needed it, and really take care of them post-operatively and postpartum. And I felt like it was the entire life cycle. And then as a woman continued to age and stopped reproductive ages and started going into the menopause and the perimenopause, I felt like it was a real, I won't say pleasure, but a very much what I was looking for in medical care. And it never turned back, never said I should have. Love what I do. Really impacted not just a woman, and this is something we've always talked about. A woman is also her family. She's a mother, she's a wife, she's a grandparent. And so you have like this extended care of an entire family. And so, I was appreciated. I still love what I do, still practice medicine. And, that's how I got into OBGYN. And then there are a lot of subspecialties like infertility and urogynecology and GYN oncology. That kind of shoehorns you into that specific type. And I feel like the OBGYN, ticket was a lot broader.
Yeah, it's true. I mean, it's particularly in the United States, and I don't know if this is true in other countries, but for most women, their OB gynecologist becomes kind of their go-to. We don't generally bother with an internal medicine physician because, we're already seeing our gynecologist once a year. And so, yeah, you develop these long-term relationships with your patients, which is wonderful.
Yeah. And life-changing. I mean, you go from, if you're in the reproductive age, you go from a couple to a family. And as an OBGYN, I'm part of that relationship building. So it really is quite exciting. One of the things that it prompted me, and I guess we'll get into this a little bit later, but I feel like the pendulum of medicine is kind of going away from that. And sometimes if you go see your OBGYN, there's a very small chance that doctor will be delivering you. They're not doing deliveries anymore. It's a hospitalist, a laborist. And unfortunately, the pendulum has shifted from that. And now a lot of the OBGYNs are doing even 9 to 5 hours like an ER doctor. And that like solo doctor or one or two partners is being, sponged up and by a big practice or by hospital-based practices. And it's unfortunate, but again, it's all part, I don't know if it's economics or the way that the medicine's going. but that's really a part of the evolution of medicine now.
Yeah, no, I think a lot of women, especially if they're reproductive, don't realize that in many cases, if they're working with their gynecology OB-GYN group, that the relationship you have may not be the relationship you get in the hospital.
Yeah.
And I think, as somebody that most of my clients that we work with and patients in my clinic and then, talk to over the last 20 years, they don't often realize that, it's just the economics of the business has really changed, particularly in the States.
Yeah.
That's very true. So you have a special heart and a special, activity and research in polycystic ovarian syndrome. And this is something that I think is absolutely underdiagnosed, underrepresented, definitely not understood. I think a lot of women suffer with it because it's a continuum and everybody thinks that if you're not on the far end of the continuum, which you can explain what that is, that it doesn't exist. And so I'd love for you to talk about how did you get interested in polycystic ovarian syndrome and how do you look at it and see it, in your patients?
Yeah, so it's a great lead-in question, and it's part of our prior question about the way the evolution of medicine has happened. So, the doctors were getting less and less time, okay? And with the patients used to be 20 minutes, 10 minutes, 5 minutes. Are you okay? This, that, here's your prescription, get out of my office. Now, what happens is when a patient comes into your office, you have the chief complaint, you have to make the diagnosis, you substantiate the diagnosis with lab tests and ultrasounds and whatnot. But very often, a doctor can tell just by 2 seconds, and not to say that I have any great shakes. Most doctors can tell when someone is in the PCOS spectrum. And I say spectrum because I think, we like to put people in silos, and we're not in silos. We're on a pendulum that shifts back and forth from day to day. And so when that patient comes in, and the doctor says, in his or her mind says PCOS, says, okay, do you want to get pregnant? No, here's birth control pill. Do you want to get pregnant? Yes, here's infertility. Goodbye. Okay. And the patient's like, what just happened? I have no idea about the disease. I have no idea about anything. And it is so frustrating. And very often the patient will come in and says she has irregular periods. And he or she says, do you want to get pregnant? No, here's birth control pills. Doesn't even make the diagnosis of PCOS. And then sends her on her way, see me in 3 months. And so it was so frustrating to me. I felt like there was this huge white space there because, I'm sure you get it as well, but every few weeks I would get another article in my inbox because I get, these research reports, summaries about this holistic answer, this exercise, this diet, this supplement, this to improve underlying PCOS. And I started talking to my patients, okay? And I started saying, what's your diet like? What's your exercise like? And very often they're doing some of the things, but they're not like understanding the mechanism on why those things are helping. And I'll share one vignette with you. I have a little thing I talk about, and we'll go into this a little bit deeper. I could go on for hours on this, but one of the things I concentrate on is exercise and why it helps and how it helps. And so I was sitting at a wedding once with my wife, and this couple was sitting next to me, and I think the mother leaned over and said, Dr. Weiss, you saved my daughter's life. Again, I didn't know this couple. I didn't know their daughter. Obviously I did know their daughter, but I didn't put it together. And I said, well, listen, I'd be more than happy to share. If you want to share, I'd love to hear it because I always want to get positive feedback so that I can help the next patient. Because very often we don't get that, whether positive or negative, to say, hey, I did the right thing or I did the wrong thing. So you don't repeat that and you try to do the right thing again. So she said, well, she has PCOS. You saw her a few years ago. She has weight issues. She had this issue, self-esteem, blah, blah, blah. She was getting like this anxiety, depression spiral and really just very frustrated with the system. She had been to 2 or 3 other doctors. And that was back to your point and something that I want to talk about too. And you said you gave her this whole like speech. And then as she's walking out the door, you said something about exercise. Now you said, what did I say? I told her that one of the roots, the causes of PCOS is insulin resistance. And the spike in the insulin causes the spike in the LH, and the LH, worsening the insulin resistance and the weight, and she doesn't ovulate, And I said, so what you have to do is after you eat, 10 to 20 minutes in the hour after you eat, do some sort of activity, not a full cardio or strength, anything, whether it be body weight squats, lunges. I actually have in my bag, and I show it to patients, these resistance bands, and I just do full body exercise in 15 minutes. Biceps, triceps, lats, squats, everything. If a patient doesn't show up, which barely happens, I'm able to do like a full body workout. And so I said that to her. I said, in the hour after you eat, and I kind of went through about it, and I didn't even realize I say these things. And she took it to heart. And that was the one thing she did that changed everything. She started cycling again. She lost weight. She actually got married, had babies afterwards. Like everything switched. Like it was unrecognizable. And you made a very astute comment about PCOS. It is by far, the most common endocrine disorder in women. Now, not just a reproductive disorder, but endocrine disorder, and often goes undiagnosed. There was a study done, I forgot who was the author of it, but it was an insane study. So it's about 10 to 15% of the female population has PCOS, whether they know it or not. They studied this one group. It was like a women's conference. There was like, I think, 1,000 women at the conference. They took them aside. They did a representative analysis. They did a study, and they said that sure enough, 10 to 15% of these patients had it. Okay. Diagnostic criteria of ultrasound. Well, talk about the Rotterdam criteria, but the ultrasound, irregular periods, and the hyperandrogenism, right? And the blood work. 70% of them didn't know that they had it. Okay. So that they found these patients that had this disorder disease, but 70% of them didn't even know they had it. Whether they had to multiple doctors that kind of just keep giving them birth control pills, but they never really talked to them about it. And it was eye-opening. I think your question was about why PCOS. I felt like doctors over the last 10 to 15 years have shrunk their time of counseling patients. Doctors have a tremendous amount of, I won't say gravitas, but power in their words. We have to start using those words and counseling the patients again and talking to them because they listen. And I said to this patient, I said, I wish my kids listened as much as my patients do. And we really need to make sure that we have their best interest and not just to rush them in, really take a time and work in it. I was telling a friend of mine who's a dermatologist, and derm sees a lot of PCOS patients with acne. And I said, you should start counseling them on these different, things that I talk about, holistic interventions that really make a difference. And she looked at me, I kid you not, and she says, the insurance companies don't pay me to counsel patients. And I was like, on the verge of tears. I was so upset. I said, why'd you go into medicine? Why'd you do this if that's not what you want to do? If you want to pop pimples or whatnot, it was very frustrating to me. So I found like this huge white space. I developed like these 7 pillars of intervention that kind of the patient now has to reframe the way she thinks and make little bits of improvement. So that was really spurred me into the PCOS space.
I think it was interesting. I've done a bunch of research in this arena, and you've got your kind of classic, I would say, genetically predisposed polycystic ovarian syndrome, which we can always go into a little bit. And then you have sort of pseudo PCOS, which is really, I think, what we see a lot more growing in our population as we become heavier and more metabolic derangement, where somebody may have, at a particular weight, had normal cycles, had everything sort of working properly. And then all of a sudden the pendulum swings and they're like, what's going on? So I think it's kind of both sides. Explain a little bit about how the predisposition for insulin resistance sort of plays out and how it may play out, in a pseudo PCOS sort of way.
Right. I think, again, in our lifetime, we've seen this real spiral of bad diets and bad, I don't want to say life choices, but just bad habits has just continued to spiral. And our bodies evolutionary have developed to sustain ourselves. So we have something called insulin, which, you're aware. And what insulin does, it tries to protect our bodies, right? And say, I want to keep the sugar, because sugar too low and sugar too high, and glucose too high is damaging to nerves and to our brains and to our bodies and to our guts and to our whole body and our ovaries. And too low, obviously, can have damage as well. So the insulin works very carefully to maintain it in the glucose in a specific zone. And once it gets too high, after you eat, your glucose normally goes up, and depending on what you eat and how you eat and when you eat, the insulin responds to that and says, okay, I'm going to take that glucose and I'm going to put it away for later. Okay, so it takes the glucose out of your bloodstream, puts it into your liver and puts it into your fat cells because the famine's coming. Insulin's always thinking about worst case scenarios. I want to prepare for the famine. Now, it really hasn't evolved into the diets that we're eating. So when you're eating a poor diet and not utilizing your skeletal muscles, your insulin is really spiking. It's really driving your glucose metabolism. And that high insulin level, just to tie it back to PCOS, drives the LH, and it kind of gets this negative feedback loop going. If your LH is too high, it makes a problem for ovulation in the menstrual cycle. So now you have this insulin that's elevated, and you had mentioned about the genetic predisposition. Patients who are, I want to say, insulin resistant or have decreased insulin sensitivity. It's the step before insulin resistance. The body keeps, producing this insulin, and it's so complex. There must be, I don't know, if a dozen, maybe even more things called glucose transporters. There are these on the cell that take the glucose out of the system and transport it into the cell. And insulin activates those glucose transporters. Too much insulin, it burns out the transporters. They don't work so effectively, so more insulin gets higher, and it kind of like the self-fulfilling prophecy. And insulin really wants your glucose to be in this range. And so it's working even harder.
If you love what you're hearing in this podcast and you really want to start working on your hormones naturally, you can get a 10% discount. Go to metabolicblueprint.com/pod, POD 10, and you'll receive 10% off your order. And again, that's metabolicblueprint.com/POD 10. Get your hormones balanced today.
Now, back to what I said earlier, I'm a little bit all over the place, and this is not the way that I talk to my patients, but remember what I said about exercising after you eat, or a little bit of exercise, 15 to 20 minutes of some action? Because the insulin, when it sees the glucose, would prefer to put it in your skeletal muscles. Because skeletal muscles, when you use anything, when you do any type of exercise, it's using glucose because that's your energy of every cell. And so when you use it in your muscles, the insulin's got to go replenish that. And so that's much more effective use of glucose as opposed to storing it in your liver and get fatty liver later on, or adipose from your fat cells. It would much rather put it into your skeletal muscles. And so once the glucose gets down into a good range, then the insulin drops, okay? So if you think about it, our diets, our sedentary lifestyles, predisposition for this, like if you have type 2 diabetes in your family, very commonly you'll see PCOS in women later on, or, difficulty conceiving or whatnot. And, PCOS has a whole huge, not to say side effects, but other issues that you have to deal with. And, a lot of times patients who have PCOS and something to that perimenopause, menopausal state is they'll say, oh, I'm done with my reproductive years. I don't really care about it anymore. And the fact of the matter is, and that is what I tell my patients, now is the time to care. You had your children, you were successful, however you got there, but now you're at risk for type 2 diabetes, obesity, metabolic syndrome, cardiovascular disease, endometrial cancer. All these things, kind of layer on top of that PCOS. When I get to my 7, pillars of success and thriving with PCOS, it's not just for reproductive health, it's for health and women's health and menopausal health. Because if you get those good habits involved and you are able to maintain them over and over, then it's life-changing. And that's what happened to this woman, the child of the people I was sitting at the wedding. It really changed her whole life.
Oh, absolutely. Yeah, because you're right. A lot of people think of PCOS and they're like, oh, if I was successful having children, or maybe I didn't want to have children or whatever, they're like, peace out. I don't care. But, I hear so much about women, being worried about whether they should take bioidentical hormones or not because of the Women's Health Initiative and this fear around breast cancer or some sort of cancer. And I'm like, look, obesity, metabolic syndrome, type 2 diabetes increases cardiovascular disease. But the reality is it also is a much larger risk for cancer than hormones could ever possibly be in a million years. And so I look at it because I see a lot of it, obviously, in the women that are perimenopausal and menopausal. So let's go in and talk about your 7 pillars and how that applies to PCOS, but particularly also the women who might be, let's say, a little more seasoned in this life.
Yeah. So, a patient comes to me and very often they're struggling with cycles, with fertility issues, and very often they're crying. The last doctor told her she's infertile, or she Googled PCOS and the first thing is infertility. And again, not only can doctors help, but doctors can do so much damage. Oh my God, if they just want the patient out of there, they'll say, well, this, that, and it's so painful to me. Very often, and I think every single day, I have to undo damage that either other practitioners have done by just throwing away words. And, our words carry a lot of, value. So they come in and they often have menstrual cycle irregularities, too much bleeding, too little bleeding, no bleeding with associated fertility issues. They have a whole host of symptoms. Some of them, all of them, and again, that pendulum, depending on whether they know that they ate well for a week and shifted themselves out, or did the right amount of exercise at the right time, or took the right supplements at the right time. They don't even realize that it's the big picture, and they put themselves out and they had a normal cycle that month for whatever, for the good reason. So they could have a whole host of symptoms, cravings, anxiety, depression, mood swings, fatigue. The list is over and over. They could have some of them, all of them, none of them. But they kind of paint that picture. That's what they present with, and that's across the board. That's not just in the reproductive age. That's also in the perimenopausal age. Whether or not it's the reproductive issues, it's the same thing. And then I didn't talk about acne, hirsutism, hair loss, where they want hair growth, where they don't want hair. And then I moved down to the diagnostic criteria, and I talk about we do lab work, a physical exam, ultrasounds, and history. And obviously, we get the diagnosis more often than not confirmed. And here's another one. Patients will come to me and say, oh, my last doctor says I don't have PCOS. And sure enough, their blood work is not classic for PCOS, but everything else is. I take a step back and I say, take some deep breaths. I say, you may not want to hear this, but you probably have shades of PCOS and you're on that pendulum and you've done good things that have helped, but you're not classic, but they're so, like you had mentioned earlier, they're so aclassical. I don't know if that's a word, but PCOS. And I say, I don't treat labs. I don't treat ultrasounds. I treat patients. And if she looks like a PCOS patient and acts like a PCOS patient, I'll treat her the same. And very often they'll respond to these 7 pillars. Then I talk about the different causes of PCOS, and 70 to 80% of it is insulin resistance, 10 to 15% is adrenal. You see elevated stress and cortisol levels, and 10 to 15% is inflammatory, and you go after the microbiome, and CRP is a little bit elevated. And so then I go down to the middle of the page and I put PCOS in the middle, and I start with diet. Now, if you've ever Googled PCOS and diet, there'll be about 15 different diets recommended and research papers that support each one of them. And I say anything that works. Pick one that you could stick to, that's easy for you, that's not cutting up tomatoes in a very small area and frying them, and it's got to resonate with you. You have to like the food that's being recommended, and it's something that you're going to internalize and do for a long period of time, because any diet will work for a short period of time. You have to maintain it, and that's the hardest part. And so then I start telling them, and then we go through the different types of diets and what are the basic caveats. What are the main pillars of a diet is increase your protein, decrease your carbs. And then I talk about nutrition as my next pillar. And they say, well, what's the difference between nutrition and diet? I go, well, diet is what you eat. Nutrition is how you eat, when you eat, where you eat. I'm sure you know about the whole food order. Okay. And I explained to them about the food order. And there's papers to support this, that if you eat even rice, broccoli, avocado, chicken, so chicken breast, you have healthy carbs, healthy fiber, healthy fats, healthy protein. But if you eat the rice first, that spikes your insulin, okay, then drives all your glucose back into your liver and into your fat cells. And then an hour later, you're craving, you're hungry again, okay, because your sugars are down and your body's like, I need glucose. And it's much easier to eat something than to get the glucose out of your liver. And then you need gluconeogenesis and you need glycogen, because glycogen and insulin work in tandem. And so the body is basically lazy and they say, hey, just eat something so that you'll get my glucose up, as opposed to don't eat, go into the pseudo fast, get your glycogen to mobilize it from your fat and from your liver. And so you want to eat your broccoli first. And so basically that'll give you a muted insulin response. Your glucose will be kind of even, and then you won't get hungry later on. You won't get that craving, and go to the proteins and kind of really draw that out. And I'll tell you, and I say this, and patients are like, I thought about this too. And I learned a lot about this when my daughter was pregnant. She had gestational diabetes. And she says, oh, rice sends my glucose through the roof. And I'm like, okay, let's talk about this. And we looked into it and we talked about it. And then I said, whenever I go to eat sushi, I'm always hungry like an hour later, right? And even though I ate a lot, it's just like, it just doesn't sustain you for a long period of time because you're getting the carbs and not a lot of protein. And then like when you go out to eat, what do they give you first? Bread and alcohol. I'm not telling you to like starve yourself and not enjoy life, but just think about it. Think about these things, about what's actually happening in a metabolic, biochemical aspect in your body. So nutrition, and then I also try to get like, what is a new relationship with food? Like try to understand that relationship with food. Like, why are we eating? What are we trying to accomplish? How is it good? And how is it bad? And so diet, nutrition, I have a lot of other things I talk about, and specifically those things. I move on to exercise. Now I have 2 main pillars of exercise. One is try to get 3 to 4 times a week of whether it be cardio or strength or weights or HIIT. Like I used to be very anti CrossFit. because I said, oh, it's so pro-inflammatory. It's dangerous. It gets you, and it's bad for your ovaries. And then I said to myself, there are people that are literally addicted to CrossFit. And I said, I'm not going to tell them not to exercise. Maybe I'll tell them to take it easy on like some of the high impact stuff, but I am not anti anything. Back to my diet conversation, anything you like to do, do it. Whether it's biking, whether it's cycling, whether it's swimming. Swimming is amazing. For women, I'd rather them do weight-bearing exercises and more strength training because I feel like that's going to give a tremendous amount of help later on in bone health. And, I always tell patients, and this is something that resonates with them, what are the top 3 reasons? And again, remember our first question to me was, why did I go into OBGYN? Because I get to see them through their entire life. So not only am I seeing the young teenager women, I'm also seeing the 60s, 70s, and 80s, and they're presenting with weak bladders, they're presenting with bone loss. And so if I can tell someone in their 20s and 30s, like I say to them, what are the top 3 things that a person gets admitted to a nursing home for? And so it's dementia, okay, and there's a lot of crossover with metabolic syndrome and diabetes and dementia. It's immobility, so they fracture a hip and they just got to get rehab, and that they can't function. They're not taking care of their bladder health or their flatulence or whatnot, their bowel health as well. So bladder and bowel health issues, and then they get admitted to a nursing home that can actually give her that extra care. All of a sudden, their eyes bug out, and they're like, "What do I have to do to prevent that?" And I say strength training, weight training, exercise, and I love Pilates. I love Pilates, okay, because it's not just the Kegels. A doctor says Kegels, okay, that's okay, but it's functioning. It's not just the muscle, the Kegel muscle. It's actually all the core that helps work everything in. And, if you've ever been associated with a delivery, there's a lot of damage, whether or not, that can happen stretching out, and you really need to work on that. So exercise, whatever you do. And then the next thing I mentioned earlier about the postprandial, after eating, doing your resistance bands, 10, 15 minutes, all the difference in the world, those 2 things. So the next circle I talk about is mental wellness. I don't talk about mental illness because if there is mental illness, we need to address it, and it needs to take the entire, visit and really make sure that patient's okay. Mental wellness is because we do know that patients that sleep well, 7 to 9 hours a night, I mean, who does that anymore? No phones an hour before sleep or right when you wake up, that email, it triggers the anxiety and whatnot and the stress, and it kind of undoes a lot of the positivity of what you've gained overnight. It decreases your anxiety, decreases your stress, and then it kind of works on that middle pillar of adrenal PCOS. It kind of decreases your stress levels. So sleeping and exercising outside, getting the sunlight. The antidepressant is the sun is unbelievable with vitamin D, and getting the exercise outside, endorphins, melatonin. It's just, anything you do without a medication is phenomenal. And so that's my mental wellness. The microbiome is massive. We're covered in bacteria inside and out that help keep us healthy and help maintain our metabolic, balance. It also can do damage. An unhealthy microbiome is associated, and this is very well proven, and it's interesting, and we can talk offline about why I think it was interesting and now it's less interesting, because it's very hard to drug a microbiome, because most of innovations are made by drug companies who think they could target something, put money behind the research, and then capitalize on it. But the microbiome is so difficult to drug. There are 1 or 2 drugs that are approved for the microbiome, but you have to have a big picture attitude on the microbiome, saying it didn't happen overnight. You developed it over your lifetime, so you're going to have to change it over your lifetime. And drug companies don't want to hear that. And so a negative microbiome is associated with Alzheimer's, degenerative diseases, autoimmune diseases, cancers, metabolic syndrome, diabetes, inflammatories. I could just go on. And it's been proven that specific types of bacteria are more associated because they have toxic metabolites. Okay. And so those toxic metabolites leach into the system and kind of cause end organ disorder, whether it be in the brain or in cancers, etc. So a lot of the things that you can do are probiotics, prebiotics, symbiotics, and foods. And I have blogs on this on my site about what you can do to kind of shift your microbiome into a healthier. Try not to go on antibiotics whenever you have the sniffles. And back to our original conversation about doctors, say, here's a script, get out of my office. I think that doctors need to be doctors again and say, hey, it's viral, you don't need an antibiotic, and try to stay away from going on too much antibiotics unless obviously you need it. I'm not trying to go away from medications, and we'll get to that in a minute, but I just think that we use way too many antibiotics, and that adversely affects our microbiome. There are many studies that show a healthy microbiome can decrease PCOS. A bad microbiome is associated with worsening of PCOS. So keep that in mind. Second to last circle and pillar of health is supplements. Now, as I mentioned earlier, I keep getting these articles and articles, this supplement, that supplement. And I started during my career, I started looking into it and recommending this supplement or that supplement. And sure enough, these patients who were sticking to the program were actually doing very, very well. And then I started looking at these supplements from a different angle. I said, there's so much crossover between type 2 diabetes and PCOS because of that insulin LH mechanism we talked about earlier. I said, why don't I go after the insulin? And so I started giving patients these supplements that have been suggested, recommended for type 2 diabetes and insulin resistance: cinnamon, chromium, turmeric, berberine. And I started using them for my PCOS patients. And sure enough, they're doing well, very well. And I'll tell you a couple of vignettes about that. But here's the bottom line is that I told a patient, I said, you need to go on this, and this, and take this. Her father went out to the drugstore and sent me a WhatsApp, because he's a friend of mine, of like 6 different supplements that I was recommending. And he's like, is this what you want my daughter to take? I go, yes. And then like the eureka moment, it said, that's crazy. That must be like $300. He's like, $364, a month on this. And I said, that's crazy. And then they don't know when to take it. And I was getting phone calls, with food, without food, before food, after food, when I go to sleep, and how many times a day. And so basically, I decided at that moment that I'm going to put this all in one supplement, sell it to my patients. I went to a patent attorney and I said, it's very interesting. I'm giving these patients a specific ratio that's never been done before. And I did a lot of research on it. Is this patentable? And we submitted a patent and got 2 patents on our combination. And it's a specific combination with red yeast and berberine and coenzyme Q and turmeric. And the most important one is inositol. And inositol has got the most data on it. And I had this one patient who literally, she had chin hair. Okay, not like mine. She had chin hair, and she's a young 20-something, and she's trying to get pregnant. And I gave her my supplement, and within 3 weeks, her chin hair resolved. And then she ran out, and she couldn't get another thing, and it came back, and then she resolved again. And anyway, she's conceived. She had a miss, but then she conceived again, and she's already has a baby since. And so I was like, this stuff really works, patented it, and now I'm selling it, as you can see. Originally, I did it with a powder. It was like a chocolate flavored powder. I wanted to be in shakes and protein shakes to try to give them a healthier, meal plan, so to speak. And some people loved the taste. Some people hated the taste. So I said, you know what? I'm going to give the patients a choice. I made it into capsules. If you want powder, just take it out of the capsules. It's 2 seconds, and you'll know exactly how much you're supposed to get, because sometimes with powder, your scoops aren't exactly the same. And so, there are other supplements out there. Maybe you don't want the whole, then you go the individuals. But this really has been doing well, and for patients. And then I started getting these patients who had a history of PCOS that now were finished with their reproductive age. And they were confronting me and saying, hey, is this good for like this perimenopause? And I said, yeah, it's the same mechanism. It's still healthy. It'll improve your cardiovascular health, decrease your risks, improve your insulin sensitivity. And so now I have a whole host of patients that are doing well, and it improves your appetite. And I couldn't be happier with it. The last pillar is medication, because I am a doctor, and there are times where patients will need infertility medications. There are times patients will need contraceptives or glucophage or glucamine or metformin. There are drugs, because not everyone is cut from the same cloth. Everyone has different history. Everyone's story to get to that point is different, and every story to get out of that point is very different. And, people are allergic to gluten. People have different exercise tolerances. So it's, life is really potpourri, a mixture of past experiences, stability. And so everyone's journey is different. And so I think that we need to be open to different paths and different enlightened, positivity.
Well, I'm so glad. There's obviously, you and I agree on everything that you said. I want to say that I'm very glad that part of your research and part of your approach is to look at the microbiome. Everybody's very hot under the collar for GLP-1s and GIPs, which have its application. We could probably go down that rabbit hole on another podcast.
Yeah.
But the reality is, my entire dissertation was looking at hormone metabolism, the estrobolome in IBS in women. And so I'm one of the world's experts on beta glucuronidase. So, I keep going back to the microbiome, and I'm like, well, maybe if our microbiome was healthy, we wouldn't need GLP-1s, right? Because most of the mechanism is in the gut. But I
Yeah.
think it's so overlooked, and it's never going to be addressed by pharma because it's too complex and too varied. But we can change it with diet. We can change it with prebiotics and
hmm
probiotics. And I think the other side is the importance of the appropriate supplements for insulin sensitization and glucose transport, right? And I think inositol gets overlooked so much, so much in that mechanism and its effect on serotonin receptors. Like it
Yep.
also helps with mood, right? So it's huge. How did you come
Yeah.
across particularly the inositol? Is it just digging through the research? Because I know a lot of people don't understand how it works.
Right. So digging through the research and then it's really broad applications. They were using it for autism spectrum, ADHD. And so it's been very, very well studied. So put on our science hats. It doesn't have the huge trials of the phase 3 randomized control double blind because it's not patentable in the unique form. What I did is I patented the combination. And so like drug companies aren't interested in anything that's under $500 million. And, because of that. And so I think that we're really suffering because we're not encouraging patients more on supplement side and on the healthy living side and the holistic side because of that. And, whenever I start my discussions, I always try to say that, we're based in the science, we're based in the research. And so no one thinking that, this is a snake oil salesman. Oh, what is this person? It's a mentality. And so when I looked at the vast amount of data and studies that have been done on inositol, it's really overwhelming. And I just had this conversation today. We have an infertility center that we kind of refer out to. And I do a lot of my own, PCOS and ovulation induction agents, letrozole, Clomid. And then a lot of other doctors just send it out. They don't want to deal with the headache. And so there's a bunch of nurses that are my nurses and also the infertility, and they come to me for some of the orders. And I said, well, are they on the supplement? Are they on the supplement? And the data shows that if someone's on inositol, even just inositol alone, their IVF or their ovulation induction works better by a few percentage points. Not just, oh, this patient got pregnant, the other ones didn't. No, actually, it's been shown in clinical trials to be more effective. And really, everybody should be on it. If you're doing any type of ovulation induction or IVF, you should just be on it. There's no question about it. I mean, there are some people that are doing it for male factor infertility. Maybe they don't need it, but across the board, it's so critical to help because it helps not just in ovulation, it helps in implantation. It helps in decreasing miscarriages. There's so many things that have been shown. Again, and you don't want to come out as like, oh, it's God's gift to the world because, there are a lot of patients that it won't be helpful for, but you want to try to get more wins under your belt. You want to try to get more facts to back it up. So the data is there and it's really overwhelming. And so I have my Google alerts for any research done on inositol and it just pops in and pretty much daily almost with another update on that. So PCOS and infertility is a journey, and anything you do to help these patients navigate that journey where they actually feel like they're in that control, they feel like because it's sometimes a very difficult journey. And so you want to give them some of the power back. And so this is just something they could do to help.
Yeah, I think, it's interesting because, some of my listeners might be like, well, I'm past PCOS concerns because I'm not, ovulating. But what we have to understand is menopause is a pseudo PCOS state, right? We're no longer ovulating. We have
Right.
increases in androgens relative to estrogen and progesterone. We are inherently more insulin resistant. We have changes to the liver. And so I've always used inositol and a lot of the combinations of what you talked about to help my perimenopause and menopausal women improve insulin sensitivity. I mean, there was some really good studies, just early studies, reversing insulin resistance with inositol alone in a postmenopausal woman. I think it's just overlooked. So that product that he's talking about, the inositol plus, could be used whether you're reproductive or not, right?
I mean, what are the top things that you have to worry about besides the, bleeding issues with the perimenopause and the menopause? Depression, anxiety, sleep. The inositol plus actually checks all weight gain, checks all those boxes. I had a patient just yesterday. She was here with her daughter and I was helping her daughter and she's like, yeah, I'm on it also. And my appetite's gone in a good way. I mean, you mentioned the GLP-1s. I'm not against them. I just really wish we would do everything else first before you got to it. And because there are still some people that would benefit from it. I feel like we just, as a society, and back to our original conversation about society's quick fix. And I would rather see them just from a young age and carry it through to the menopause, have good habits, and you'll see everything will line up. And it's very hard to treat disease. It's a little bit easier to prevent disease. And so some of the simple things that have really no downside. The safety can improve your mood, improve your anxiety, help with your weight issues in the postmenopause. All these things, check all those boxes, but you're 100% correct that it's like a pseudo PCOS side because estrogen is down. The androgens, the testosterone and DHEA are higher just because of relatively speaking. And anything you can do to improve that ratio is good. And I don't want to go into the HRT, but I'm a big fan of HRT. I remember exactly where I was standing when Wyeth sent out their FedEx. Listen to this. They FedExed a letter with the WHI. It was in 2001, the WHI results a day before they were released. They wanted the doctors to be prepared for all the phone calls they're about to get. And I opened it and I'm like, this is insane. And I remember, I clearly tell you where I was standing in my office. And when I got the FedEx from Wyeth, and it's been debunked over and over again. And I mean, I tell you, every day I have a conversation with a menopausal woman about hormone replacement therapy, bioidenticals or otherwise. And it's such a shame. We've done such a incredible disservice to a whole generation of women.
Yeah.
It's so sad.
Absolutely. No, I agree. I mean, I definitely see it. We have a specialty in my group with osteoporosis, right? And so, every woman's like, why? I'm like, because you went through menopause without hormones. Yeah, guess what? Menopause, osteoporosis is a risk, period, right? Just depends on how much bone you built before it goes through. So I agree. And that's a whole can of worms, but it's all part of the picture. This is the first time, really in history, if we look back at 1900, most of us only lived to about 57, but, so it wasn't really a big concern, but now we're living 30, 40 years after hormones. And that just, adds to the metabolic derangement when we don't have them, so where can people find you? And I know we've got an offer for your product. We've got a 10% offer that we'll put in the show notes. Tell my listeners where they can find you and your product.
So I'm at provationlife.com. You can actually book a consultation with me. We do 15 minutes, half hour, just to kind of get a flavor of what you're going through, because I'm a big proponent of the individual, the care. You can't get, I'm on, all the socials, but I find like it's too much noise and too much this, too much that, and this person's experience and that person's experience. And then all of a sudden you'll start with this diet, you'll take this spearmint tea and this tea and that. And then being a jack of all trades, master of none, you need to individualize the care for you and how it applies to you. So I frequently write blogs. I frequently write about my experience with patients. And so you can find all my blogs at provationlife.com, and hopefully it'll be in the show notes. We do have a 10% off discount code for the new capsules that you can purchase online. And we're really excited about, PCOS is, I don't want to say it's an untapped market, but it's a hungry market. And it's a place where we could really, really make a difference and really make a change. Well, that's what I try to do. And that's why I went into medicine. And that's why I went to OBGYN. And, it's pretty exciting. So I look forward to, we could go on and on about GLP-1s. We could go on about, specific HRT and WHI. It's, there's a lot to talk about. It's frustrating that the media, I don't think, is our friend. I think they are also in it for themselves. And, we could talk about pharmaceutical companies. I worked at one for quite some time, and it's been a journey.
Yes. Yes. Well, thank you so much, Dr. Weiss, for being on the show and sharing your knowledge and experience. I know my listeners will be so happy to hear it, learn a lot from this conversation today.
Yeah. Thank you very much. I'm also eager to get out there, and this was a wonderful platform, and I wish you the best and success, and continue to help patients with, with energy and enthusiasm and positivity. I always talk about, just to close, if we have a minute, I don't know if you know this thing's James Clear, Atomic Habits, right? Yeah. I recommend this to all my patients. And I say, one of the most impressive things about that book was even the intro. Basically, we think that you put your effort in and the time and you're going to reach the goal. You think it's linear and you think it's binary. You think 1, 1, 1, 1, 1. It's so not. Basically, patients come out and they do their exercise, whether it's saving money, whether it's losing weight, whatever the case is. And after 2, 3, 4 weeks, after a month, they're no closer to their goal. They just fall off. And there's this, we call it the valley of despair, the valley of failure. And it's like 95% of patients. And so what I try to tell patients is, don't put a goal, don't put a number at ovulation or pregnancy or weight loss or whatever it is. You want to incorporate those good habits that you're doing into your life. And all of a sudden, you're going to look back and say that, the goal was directional. And all of a sudden you're going to be up here at your next goal. And you're going to look back and say, hey, I hit that goal. I'm on to my next goal. And you just continue on that direction. So my blessing to you and to your patients that follow you and the listeners is continue in that goal and continue in that direction. And don't get discouraged with setbacks, and don't get discouraged with, not to say failures, but everything is temporary. Change that mindset, make good habits, because that's what's going to carry you. And that's the most important thing about the patients I talk to with PCOS, because if you get the good habits now, they'll carry you through the post-PCOS life, the premenopausal, the perimenopause, and then the postmenopause. And that's the best thing you can do. Because you know what the number one correlation activity is with long life and healthy life is activity and exercise and movement and good habits. And that's the most important thing.
Absolutely. It ages us in reverse. It's the only thing that's shown to do that. Well, awesome.
Yeah.
Well, thank you again for being with us at Menopause Mastery. And if you're listening and you really loved this show, give me a thumbs up and a high five, a 5-star review. It just helps us get more guests. It helps us in so many ways. Thank you for listening, and I'll see you next week.
Thank you so much for tuning in to the Menopause Mastery podcast. You are why I'm here, and I am so very grateful. Hit subscribe so you don't miss any wisdom on creating the most exceptional life on our terms. If this episode has helped you in any way, please share it with a friend to spread the love, and together we rise. You can follow me on social media at Betty Murray, PhD, and you can reach me online at bettymurray.com.